Good evening, everyone, and welcome to another ESG Wednesday webinar. It's my pleasure to be here. My name is Ian Gralnek, and I am the Chief of Gastroenterology at Emek Medical Center in Afula, Israel. I'm actually pulling double duty tonight because Professor Triantafilo will not be able to join us tonight as moderator. So I'm going to moderate. I'm also going to speak, and I'm joined by my colleague, Dr. John Karstensen, who is a surgeon and an endoscopist from Copenhagen, Denmark. It's my pleasure to have him here. And tonight's topic is going to be on endoscopic therapy and esophagogastric variceal bleeding, what you should know in 2021. So I just want to remind everybody, this is now the fourth consecutive year that ESGE is offering webinars. They are now on usually every other Wednesday, sometimes every Wednesday of the month. At these ESG webinars allows everybody to view high quality presentations on the hottest endoscopy topics from world leaders in endoscopy. It also allows interaction between you, the audience, and us, the speakers. And this is a good opportunity for me to remind everybody you can use the Q&A function on Zoom to be able to send me tonight questions that I will be able to either relate to myself or to relate to Dr. Karstensen. The other thing that's great about the ESG webinar Wednesdays is that it's completely free. Okay, so let's get started. This is my disclosure slide. And we're going to split this into two sections. I'm going to talk about esophageal variceal bleeding, and Dr. Karstensen is going to talk about gastric variceal bleeding. So this is a clinical case. This is a 55-year-old gentleman who presents to the emergency department with acute bloody hematemesis ×3. He has a history of alcoholic liver disease, and 6 months ago he presented the same way, and at that time was endoscoped and was found to have bleeding from esophageal varices. They were treated, and then he was lost to follow-up. This is actually not an uncommon story. So he comes back now to the emergency department with recurrent hematemesis. So we're assuming here that this is recurrent esophageal bleeding, but I want to remind everybody that there are data to show that even when we suspect variceal bleeding, up to a third of those patients may have a non-variceal source when we actually do the endoscopy. But he comes in and he's tachycardic, he's mildly hypotensive, his hemoglobin, at least right now, is 9.1. He has borderline low platelets, 105,000. He has an elevated white count. His transaminases are elevated. His bilirubin is 16. He also has some synthetic dysfunction. He has an INR that's elevated at 1.8, and he has a low albumin at 2.9. So what are the goals of therapy? Well, they're to restore and maintain hemodynamic stability, to maintain tissue oxygenation, to control the bleeding, and of course, to also prevent recurrent bleeding and mortality. I also want to highlight Dr. Karstensen published a cascade guideline in Endoscopy International Open just a few months ago. This was a cascade guideline on management of variceal hemorrhage. I'm also going to put out an advertisement is that later in 2021, the ESG will put out a comprehensive full guideline, the first time that we've done this on endoscopic management of esophagogastric variceal hemorrhage. Okay, this is more for your education and knowledge. I'm not going to go through this right now in detail. This is the ESGE guideline on portal hypertension. Specifically, this is a very nice algorithm on management of variceal bleeding. This was published 2 years ago in the Journal of Hepatology. The Americans also have a guideline looking at this that was published back in 2017 from the AASLD. And there was actually a follow-up, a very nice review on this with this very nice algorithm, again, looking at management of variceal hemorrhage that was published as a review from Garcia Sao. And lastly, there are also guidelines on variceal hemorrhage, which is also very nice because there's a subsection on what to do during esophageal variceal bleeding, as well as what to do during gastric variceal bleeding. And this guideline was published now 5 years ago by Trapathy in Gut 2015. Okay, so what should we be doing pre-endoscopy in these patients who we suspect to be having variceal hemorrhage? We need to volume resuscitate these patients carefully, initially using crystalloids, and I'll tell you more about this in a minute. We want to start already in the emergency department, vasoactive drugs. Prior to upper endoscopy, we want to make sure we're giving antibiotic prophylaxis because of the risk of infection. You can consider giving an upfront PPI. Again, this goes back to that up to a third of patients, although we suspect that they may have variceal bleeding, they may actually have a non-variceal cause. Now, if they do have varices, you can always stop the PPI after that. You can consider prokinetic agents such as IV erythromycin. In these patients, these chronic liver disease patients, if they're encephalopathic or they're having active hematemesis where they're not able to control their airway, you can consider endotracheal intubation prior to upper endoscopy. And in these patients that we suspect to have variceal bleeding, we should be scoping them within 12 hours of their presentation. But a key point here is we should be doing this after they are hemodynamically resuscitated. So we correct the fluid losses initially with crystalloids, again, doing this very carefully. If we are going to treat them or transfuse them with packed red blood cells, we should be today following a restrictive blood transfusion policy. What does that mean? It means that less is more. We know that when we give less packed red blood cells, that there's lower all-cause mortality as well as lower rebleeding rates, especially in patients who have portal hypertension and are bleeding from varices. This has been shown by the New England Journal study by Villanueva, as well as in a systematic review that was published in Lancet Gastroenterology in 2017. When should we be transfusing? Really sort of the trip point to transfuse a patient would be once their volume resuscitated or they're hemodynamically stable if their hemoglobin drops below 7. In those patients who have cardiovascular issues or vascular issues, then we may want to transfuse them if their hemoglobin drops below 9. The target hemoglobin after transfusion should be somewhere between 7 and 9 or 8 to 10 in those vascular patients. Okay, we should be starting vasoactive drugs, as I said, in the emergency department. The two most common medications that we should be using to reduce portal pressures is octreotide as well as terlipressin. Terlipressin is a vasopressin analog. Some places in the world actually do give somatostatin, but the two most common medications for this is starting out octreotide or terlipressin in the emergency department. We no longer use vasopressin because of its significant cardiovascular side effects. Very important is we should be giving prophylactic antibiotics. As I said earlier, before upper endoscopy, the drug of choice here is ceftriaxone. It's 1 gram every 24 hours. We will give that before the upper endoscopy. Some places do use norfloxacin. You need to consider the local antibiotic resistance wherever you are practicing, as well as patient factors, including allergies to medications, of course. And then this should be continued for about 5 to 7 days. This was shown in a meta-analysis almost 10 years ago that prophylactic antibiotics in these types of patients, cirrhotic patients who present with upper GI bleeding, that if we give them prophylactic antibiotics, that it significantly reduces overall mortality as well as mortality secondary to bacterial infections. Lastly, before endoscopy, if we are concerned that the patient may have blood and fluids, clots in their stomach, we can use erythromycin or a promotility agent. Erythromycin is my agent of choice. We will give in those situations erythromycin 250 milligrams IV about an hour to 2 hours before the planned upper endoscopy. However, you need to make sure that the patient does not have a macrolide allergy or that there's no known prolonged QT interval. So endoscopic therapy, what should we be doing here? And you can see here, this is an actively bleeding esophageal varix, and there's some very juicy esophageal varices here with vein on veins being shown. The goals of endoscopic therapy is to stop bleeding, to prevent early rebleeding, which is defined usually within 5 days, as well as to prevent late rebleeding, and in an attempt with secondary prophylaxis to eradicate the varices. So the treatment of choice for esophageal varices is endoscopic band ligation. You can see here, this is the band ligating device with the clear housing. but the treatment of choice today is band ligation. I'll talk about some rescue therapies momentarily if band ligation is not working or if you don't have the ability to use band ligation. This is the ESGE algorithm that I talked about before. Again, I want to reiterate, these patients who we suspect to have variceal bleeding should really be endoscoped once they're hemodynamically resuscitated, but within 12 hours of presentation to the hospital. If we confirm variceal bleeding, then we perform band ligation. And I'll talk about afterwards what we do in those cases, whether band ligation is successful or they have rebleeding. So this is our patient that I talked about who had bled 6 months before. He comes back with the hematemesis. We've now done all these things prior to endoscopy. He's been resuscitated. He got a little bit of blood products. We gave him some erythromycin as well. He's on octreotide before. And this is what we're going to show here at endoscopy. I'm going to run this for you, but you can already see here in the still, this is what's called a platelet plug or a nipple sign. Some people even call it a volcano sign, but this is really the site of bleeding where this patient bled from. And I'm going to show you this as we run this video here. So you see there's about 4 or 5 columns of varices here, and you see this nipple sign right here on this varix that's in about the 11 or 12 o'clock position. Didn't catch it there, but you can see it there in the distance. The reason I want to show you this is that this is where we need to start banding. If we start to band around this area, there's actually the potential that that could cause this to start bleeding. So this is really, you want to find this site, and this is where you're going to place your first band. So this is what we did. This is the same patient. You see now the banding device has been placed on the tip of the gastroscope. We're going to go down and we're going to look for that nipple sign or that platelet plug. And that's where we're going to place this first band. Once we place that first band, then we're going to put our additional bands. And you see it's already started to bleed a little bit. It started to ooze here. And we're going to suction that nipple up into the housing. What you want to do is you want to red out the entire screen. So sometimes you need to wiggle the scope around. You need to make sure you're giving suction. And you want to just keep holding on to this, holding on to this. You can move the scope a little bit back and forth gently, bring it all the way up so it reds out the scope. Then you're going to deploy your band at this point. So we're going to deploy the band, and now you're going to see here, there's still a little bit of oozing, but you're going to choke off that place that was actually led to the bleeding, okay? And the reason you want to red out the entire screen is because you want to maximize the amount of varix that's drawn up into the clear housing and it gets banded. Okay, this is just a video of another patient who has active bleeding. This is from Elsevier, but I thought this was a very nice example. Mostly today with vasoactive medications, patients have already stopped bleeding by the time we endoscope them. But in this case, the patient is still bleeding here. You want to find, again, that site that's actively bleeding, and that's what you really want to band initially. So you're going to see this here. It's at about the 2 o'clock position here. You're looking for it. You're seeing right here. Now, all of a sudden, you see what's sort of squirting there. You're going to hold that area. You're going to suction up that varix and that site of bleeding into the scope. And again, try and red out the entire scope, maximize the amount of varix that's suctioned up, and then deploy the band. And now you'll see it here, and there's actually no more bleeding, okay? So the takeaway message is really to band initially that site of where you think the varix had bled from. So here are my technical recommendations for esophageal variceal band ligation. You should be using a diagnostic size gastroscope that has water jet capabilities. You want to make sure you have adequate suction. You can turn the suction up. You want to apply that first band to the site of bleeding, either whether it's actively bleeding or a nipple sign or a platelet plug. You want to completely red out the screen so you maximize the amount of varix. And then what you want to do is you can apply the additional bands coming proximal, but including the other variceal columns while you're banding upwards. Usually it ends up being about a total of anywhere from 6 to 10 bands that can be applied. What about rescue therapy? So let's say band ligation is not able to be performed, they're actively bleeding, you can't see or you don't have a band ligator, we can still use sclerotherapy. You can use athenolamine, sodium moreuate, sodium tetradecyl, polidocanol. So you can use that in order to get acute control. There's also emerging data that topical agents, so TC325, also known as hemospray, may be efficacious in patients who have esophageal variceal bleeding, but these are really rescue therapies when band ligation is not an option. Now, what happens if everything fails and the patient is really massively bleeding and you just can't get control? Then you're really going to have to put down a Senstake and Blakemore tube or some type of a tube that has an esophageal balloon. You're going to be able to inflate the esophageal balloon, and you always need to get a chest x-ray or an abdominal x-ray afterwards to make sure that's in place. The other important thing not to forget is that when you do put in a Blakemore tube or some type of a balloon tamponade, it's only a temporizing measure. It really should not be left in for more than 24 to 36 hours. Otherwise, you're risking variceal or esophageal necrosis. The other option in this situation is to put in an esophageal stent, specifically an Ellis stent, which again is a temporizing measure, but that can be removed later for more definitive therapy. All right, let's go back to this ESGE algorithm. Let's say that band ligation, you have it, you've done it, it's succeeded. Now what you do? Well, probably 85% of patients are going to do fine. Your band ligation is going to be effective. So in those cases, if they're high risk, and what's high risk? So child C with a child C score of 10 to 13, or potentially with a MELD score of 19 or greater, TIPS should be considered at that point because they're very high risk for later rebleeding. In those patients who have early rebleeding, then you can go directly to TIPS at that point as rescue therapy. Now, if you have Child's A or Child's B patients, then those patients can be brought back for repeat band ligation about every 2 to 4 weeks. And really the goal of therapy there is to prevent ongoing bleeding and to eradicate the esophageal varices. These patients should be started on a non-specific beta blocker such as propranolol or nadolol. Hepatologist, if you really are not familiar with taking care of chronic liver disease patients, my recommendation is to have hepatology involved. And of course, if these patients rebleed, they should go for TIPS therapy. And I want to thank everybody for listening to my portion of tonight. You can follow me on Twitter if you'd like to. And it is now my pleasure to introduce Dr. John Karstensen, who is going to talk about gastric varices. I see there are some questions on the Q&A, John, but I think what we're going to do is we're going to wait till after your talk, and then we'll take the questions together. Okay?
Yeah, thank you very much.
Okay.
So I'm going to talk a bit about gastric variceal bleeding tonight, and thank you very much for the opportunity. First of all, I'm going to talk a bit about how to classify them, because that is quite important when it comes to treatment. So you have gastroesophageal varices type 1 and 2. Type 1 is on the lesser curvature, while number 2 is going into the fundal region. You also have the isolated gastric varices, type 1, which is in the fundus area, and type 2, which is in the rest of the stomach. You can see here that the GOV1 is the most frequent. However, the one in the fundus, so GOV2 and IgV1, is those who are most prone to bleeding. Now, how do they actually look? It can be difficult to see. But here you can see there's a small vessel here, and this the mucosa looks normal. And if you have a bit more distance, then you can see there's a complex set of varices here. When we see these during endoscopy, we always do an endoscopic ultrasound, and then it's really easy to see that this is a really big complex of varices. You can see that there are vessels with the inflow, and there's also some with the outflow. It also enables you to measure how superficial the varices is placed, and you can see up here that's only 1 millimeter, so it's quite superficial. I also brought a case tonight. So this is an 18-year-old, otherwise completely healthy female that was brought in the middle of the night with a hypovolemic shock and severe upper GI bleeding. She went to an emerging gastroscopy, and she had banding, band ligation of her esophageal varices. In the morning, just to explore the etiology, we did a CT, and it showed that she had a portal vein thrombosis. During the day, she encountered another episode of upper GI bleeding and went to repeat gastroscopy. So this was what we found. There's a gastric varix there. It's a bit of oozing there. It's a GOV2. So we decided to go for glue. So we're in the retroflex position. We installed the glue, and that way we reached the hemostasis. So that was a good story. Now, let's take a look at the evidence behind that treatment. So primary prophylaxis, if you have a gastroscopy and that's what you see, there's no history of bleeding. What do? Well, there's several case series evaluating treatment for gastric variceal bleeding, but also primary prophylaxis. There's one here. It's from the group of Ken Binmuller. You can see that it's quite large, 152 cases. But when you want to interpret these case series, you have to look at the indication. And you can see down here that only a quarter of the patients were treated with the indication of primary prophylaxis. You can also see that only fundus varices were included. So the most common one, GOV1, was not included. You can see that the results are quite encouraging, technical success of 99%. And you can also see that the risk of post-treatment bleeding was only 16 after a follow-up of over a year. Again, primary prophylaxis, there has been a randomized controlled trial comparing glue with beta blocker treatment and no treatment. And you can see that there is a significantly lesser risk of bleeding in the glue group compared to the other two groups. However, the survival were comparable between the groups. So there's very little evidence on the area, and that's probably why we also have a recommendation for primary prophylaxis stating that we don't recommend interventional endoscopy in these cases. Instead, we recommend the instigation of beta blockers. Now, in the next case here, we have to do something because this varix is bleeding. So which endoscopic technique to use? Well, first, we don't have to think about endoscopic techniques. We have to take care of the patient. And like Ian also emphasized, we have to protect the airway. We have to maintain sufficient blood pressure, restrictive or balanced blood transfusion. And although the evidence is quite limited for gastric varices, we do the same things with antibiotics, vasoactive agents, lactuloses and cirrhosis. And then, of course, we have to go for an urgent endoscopy. Now, endoscopic band ligation, we know that very well from the esophagus, where it's quite common, so we all know that. How about using that for gastric varices as well? Well, there has been 3 randomized controlled trials, and they have been compressed into this Cochrane analysis, and they suggest that due to a higher risk of rebleeding, endoscopic band ligation is inferior to glue treatment. So they prefer glue. And however, in some cases, especially in GOV1, the use of band ligation may be appropriate. So what about glue and coiling? First of all, we have a local recipe from my own department for how to make glue. We usually use regular injection needles. So these are needles we know from peptic ulcers and EMR. We have to know the dead space, that's quite important, and we have them here. We start with flushing it with lipiodol, so it gets really smooth. And then we empty the needle. So then we install a mixture of the lipiodol and the glue. This is hysteracryl. And then we make a valve with a sterile water that is equal to the space of the needle. So when the needle enters the varix, I'll show you an example in a few seconds, then we inject the water into the needle and the glue gets installed. You can flush the needle outside the varix and do it once again, or you can have a second needle ready, which we actually prefer. You can inject 2 to 5 times of glue or until you reach hemostasis. So a small example is now in the duodenum. You can see there's a small varix there. So if we flush it a bit, then it'll start bleeding. So we go for glue. Let's see if I can start it. There we are. So we just press, we get pushed a bit away. Let's see how it goes. Now we're back a few seconds later. You can see there's a little bit of oozing bit. You can also see there's a bit of glue on the screen. Now we can insert and we get another portion of glue and then we're reach hemostasis. So how about coils? This is an old educational video from Ken Benmøller. Showing how to deploy them. These are deployed by endoscopic ultrasound. You can see here that how the coils are deployed in a glass of blood, and it makes a really nice clot that can be used to obliterate the varix. So this is in the US from one of my supervisors. And that's, here you can see a really nice feeding vessel here. The red one, that's the vessel going towards the echo endoscope. And no doubt that's a big varix. So what we did here was we went for coiling. So from the upper left corner, you can see the needle transversing into the varix. And in a minute, you'll see that there is a small coil being deployed here. I'll just put them here. So we placed another coil and then finally we went for glue. And it's quite easy to see here that the flow has now stopped and the varix is obliterated. So there's been some randomized controlled trials comparing the different techniques here. There's one from Robles and Miranda here. And you can see they compared the combination treatment that I just showed you with coils alone. Again, have to look at the indication, and you can see that the majority of these were actually for secondary prophylaxis. However, the results of the combination treatment is quite good. It's superior both in terms of varix reappearance and reintervention free time, and also the number of reinterventions. There's been a meta-analysis comparing these techniques, and it's quite obvious that the rate of adverse events for glue alone is much higher compared to both coiling alone and the combination treatment. You can also see that the rate of reintervention is much higher for glue alone compared to the combination treatment, as well as the rate of rebleeding. So combination treatment is probably the way to go. Now, how about endovascular therapy? Ian just touched a bit upon tips, but just here a few days ago, there was actually a really large randomized controlled trial evaluating the use of balloon-occluded retrograde transvenous obliteration for secondary prophylaxis. So this was after the bleeding has been controlled. And here you see that you go either from the transfemoral or transjugular, and you go from the systemic to the portal system via a shunt. So you need to have a shunt here, and it's usually a rhinogastric shunt. If there's no shunt, you cannot do it. So they included a 32 in both arms. Again, only a shunt were included, and these were only cirrhotic patients. You can see that the results were really encouraging for BRTO. The pre-all-cause rebleeding rate was much better for BRTO compared to glue therapy. But also you can see that there were actually none of the varices that were treated that bled during a follow-up of 2 years. So that was quite encouraging. I should also mention that for the BRTO treatment, when you do that, you often see an aggravation of the esophageal varices. So as part of that arm, there was actually also an endoscopic band ligation of the variceal varices, of the esophageal varices, sorry. Now, the recommendations for when it's bleeding of secondary prophylaxis is that you should use glue or a treatment of glue and coils, and maybe there's room for a endovascular arm as well during the future. So as Ian just pointed out, we made a cascade guideline last year, and some of the stuff that we have been discussing here is a bit high tech, and in many environments they are not available. So what we did here was we took the Baveno guideline, which is kind of the Bible for how to treat these variceal bleeding, and we broke them down and inserted them in different resource levels. So for instance, if you take the recommendation about endoscopic therapy and using glue when it's bleeding, then we went through different sceneries. And we, for instance, if we have a limited setting here, we said the endoscopic band ligation can be considered if you're not if you don't have glue. So these are recommendations that can be used in a resource-dependent environment. This looks really nice when you install the glue, but if you press on the fluoro, you can also see there's a lot of glue inside the vessels. And can you do that without adverse events? No, of course you cannot. There's always adverse events in some cases, of course, but most of them are mild. We often see fever and a little bit of pain, but there's also pulmonary embolisms. There's also really severe cases here. You have a case where it has traveled all the way up to the cerebrum. So we have to take care. Now, what about rescue therapy or salvage therapy? Ian just spoke a bit about the 16 Blackmore tube, and it's really good for fundus variceal bleeding. However, I would really like to emphasize that you should be sure before you inflate it that it's all the way down to the stomach. You should do that either on fluoro or endoscopic guide, because if it's in the esophagus and you inflate the gastric balloon, you will fracture the esophagus. So it's a bit dangerous. Take care. Other solution is always, as always, to repeat the endoscopy, maybe with a more experienced colleague. You can also do interventional radiology. We have discussed that a bit. And then there's shunt surgery, which is actually recommended by the Baveno for all children, or it has to be considered for all children with portal vein thrombosis. And then there's in selected cases also the possibility of doing a liver transplant. So take-home messages, if you want to evaluate them, you should do an EUS. Primary prophylaxis is non-invasive. When it's bleeding and for secondary prophylaxis, you use glue or a combination of glue and coiling. There are adverse events, most of them are mild, but some of them may also be severe. Salvage treatment include interventional radiology and zinc-staining Blackmore tube, just using the gastric balloon. So I want to just thank my supervisors, and thank you very much.
John, thank you very much. This is really good because this leaves us a fair amount of time for questions and answers. We had over 600 people listening to this. So I want to thank everybody for attending, and we have a lot of questions that have come in. So John, I'm going to start with, I don't even know where to start here. What would you do with a duodenal varix, John? Would you band it? Would you glue it? Would you treat it as an ectopic varix? What would you do? Somebody's asking.
We would for sure go for glue if it was amenable for that. If it was just as I showed you in the video, if it's just in front of you, we would go for glue for sure.
Okay. I'll ask you and then I'll give my answer. Go ahead.
But for sure, you're in an area now where the evidence is really not robust. So I think this comes down to personal preferences and experience when you're talking about duodenal varices. But I think we'll go for glue.
Okay. Somebody asked, staying with the glue issue here. Somebody asked, what if Lipiodol is not available? What do you do? What do you use? There's glue that you don't have to use Lipiodol.
Yeah, I think we would just go without Lipiodol. Actually, I just read there was a guideline just coming out yesterday from the AGA, and they were actually a bit discussing whether you should avoid Lipiodol, because maybe some of the fever cases we have, some of the pain, or we have a lot of these fevers. Maybe it's the Lipiodol that is causing these. So if it was not available, I would go without.
Okay, and what's the amount volume that you inject of glue? You may have said that, but I was fielding all these questions, so I wanted to hear what you guys use.
Yeah. I think we'll go somewhere between 2 and 5 milliliters, something like that. Yeah.
Okay, and do you do it as a slow push, or because there's some people say that if you push it slow, you may have less risk of embolic effect versus just sort of pushing it?
Just pushing.
Anything like that?
I think I've never thought about that. I've never thought about whether it was quick or not.
Okay. All right. No, that's fair. All right. I'll take a couple questions now. Somebody asked, so it's really for both of us though. Somebody asked about, they said that Senstake and Blakemore tubes are no longer available. And they wanted to know if we knew if that was true or not, and if there's any other balloon tamponade tubes that can be used. I am not aware that Senstake and Blakemore tubes are no longer available. The only other tubes that I'm really familiar with is there's an old Minnesota tube, and then there's a Linton tube, but the Linton tube, as I remember, just has a gastric balloon, does not have an esophageal port. Have you heard anything about Senstake and Blakemore tubes not being available on the market?
No, I have not. But when I did this presentation, I was just discussing with my colleagues, and I think that it's maybe once a year we use it, so it's really rare. And we never use it for esophageal varices anymore. So it's just in these cases. I've heard about the last tube that you just mentioned. It's called Lincoln.
Linton, L-I-N-T-O-n. Yeah, Linton tube.
Should have had. I don't know it, and I don't know where who produces it.
No,
I must be honest.
Yeah.
And I have not heard that they are not available anymore. The zinc-staining Blackmore.
Okay. Do you ever give glue as a rescue therapy in esophageal varices? So not the usual sclerosants or TC325. Would you ever inject esophageal varices with glue as a rescue?
I don't think so. I think our rescue treatment is the stent, is using the Ellis stent, and that we use quite a fair amount of time. So I would say once a month, maybe something like that. No, I have no experience with using glue in the esophagus.
I don't either. How long do you leave the Ellis stent in for if you deploy it?
24 hours
Okay.
maximum.
That's, yeah, exactly. Again, because you're risking potential esophageal necrosis. Okay.
Yeah.
Somebody asked a question about would you use prophylactic antibiotics in a cirrhotic patient? You're assuming that they bled from varices, but then you actually go down and they have a peptic ulcer bleed. Do they need to be on prophylactic antibiotics? I know what my answer is, but I don't think there's a lot of data on it. Would you
I
continue
think
it
we'll
or
go
would
with
you
your
stop
answer.
it? My answer would be is as I would say yes, especially in those patients who we would fear or be concerned that they actually have ascites, because there can be bacterial translocation. And even with mucking around down there endoscopically, I'd be concerned that they still could be at risk for SBP or a higher mortality. So I would continue the antibiotic because I think the downside of giving the antibiotic is quite low as compared to what could be the potential adverse events. Okay. And I
That's a
believe,
good point.
I believe that the meta-analysis that I quoted was not just limited to cirrhotic patients who had variceal bleeding. I think it was all comers. I'm not 100% sure. I don't 100% remember, but I think it was all various types of upper GI bleeding and not just limited to variceal. Oh, okay. Another question. PPIs. Do you put patients, this is really, well, would be for gastric too. Do you put patients on PPIs after you've treated their gastric varices? And they asked me, do I put them on PPIs after I've banded esophageal varices? I'll let you go first.
No, I don't think so.
Okay.
No,
So,
because it's not the indication. It's for peptic ulcers. I don't think it would help the patient.
So we do it for sure. We do it for esophageal, and the reason we do it for esophageal is because of the potential for post-band ulcerations and to try and decrease the acid that may be washing up into the esophagus. But there's also some data to show that PPIs may be detrimental in terms of, I believe, increase in encephalopathy in patients with chronic liver disease. So you sort of have to balance that. We don't put them on them forever, but you need to be aware of that if you're going to use PPIs for a longer term in these patients, in chronic liver disease patients. Wow, there's a ton of questions. There's like, I can't keep up with these. Somebody asked you with EUS and treating gastric varices, what coils do you use? What size coils do you use? And actually, do you know who makes those coils?
I have to be honest, we don't use coils really often, so I don't know the specification on which company that we prefer. What we usually do is we do an evaluation with the US, and then we go back to the the conventional gastroscope, and then we do our glue by gastroscopy. That's how we usually do. We don't have a lot of experience with the coils. We have only done it in some cases where the varix was really big, and it was not realistic that we could manage it just by glue.
So what we do, and we don't have a lot of cases of gastric varices in Israel. I mean, we have them, but it's not like what I saw when I was in the United States. We use the coils. I don't do EUS, but my EUS person will do these cases, and they will actually treat the varices using the EUS scope, because you can actually see they'll first put in the coils. The coils they get are actually from cardiology. It's the coils that cardiologists use and also the interventional radiologists use as well. I don't know what the company is, so I'm sorry I can't answer your question 100%. But the technique basically is under EUS guidance to first put in a coil or two coils and then inject the glue, because the coils act as a scaffolding, and the glue gloms onto it, and then it can cause thrombosis there of the varix. Somebody asked about, do you use prokinetics before, like erythromycin or metoclopramide before endoscopy?
Yeah, because as you also stated, you never know what you're going to find. So the pre-endoscopy setting is often it's included in the pre-endoscopy setting for something that is bleeding. It's just to increase or improve the view when you do your endoscopy. So it's a good trick actually. So yeah.
Yeah, we will too if we suspect that there's blood, because there's data to show that it does clean out the stomach and leads to better visualization and a less need to repeat your upper endoscopy because you've actually may have missed something. Somebody said that erythromycin is not available some places around the world, and are there other prokinetic agents that can be used? And the answer is yes. There's some data on the use of metoclopramide, 10 milligrams IV. There can be adverse events with metoclopramide, and the data is not nearly as strong for metoclopramide as with erythromycin. So that's the answer. The other question is, somebody was asking, because I had said that really if you see the nipple sign, do you really ban that first in esophageal varices? And my answer was yes. At least that's what I thought the literature shows. And they had said, well, aren't you supposed to band around that? My answer is that you band where the site of bleeding was first, and then continue to add your bands. The most likely spot of bleeding in esophageal variceal bleeding is in the distal 5 centimeters of the esophagus. So usually you are going to start down by the LES. Usually that's where you're going to find either active bleeding, or you're going to find the site where you believe the point of bleeding was. Sometimes you can do an upper endoscopy and you really can find. Now in those situations, what you should do is you should start down down by the LES where the esophageal varices start, and start to place bands and then move up proximally. But if you do have a site of active bleeding or a nipple sign, my recommendation is still that that's really the place that you can start. If you feel you need to go more distal, you can. You just need to be careful to go around that banded varix so you don't knock off that band. Am I making sense, or John, am I off in left field?
No, I'm all ears. It really makes sense, I think.
Okay, all right. I'm looking to see if there are other questions. There's a lot of other questions here. Let me scroll down here. I wrote a bunch of them down earlier. Any role for esophagectomy in variceal bleeding? My answer is no. John, what do you think? Esophagectomy.
I've heard of it, but I have absolutely no experience. And I think if you have a cirrhotic patient, I'm a surgeon originally, and I know how they respond to surgery. I think it would really be it would not be an ideal idea. And if you need something for rescue treatment, go with stent or tube. Something else, don't go for surgery in these cases.
Is there any role for surgery, somebody asked, in gastric variceal bleeding today?
No,
aside from liver transplantation. I mean, shunts are almost not done anymore today.
No, I don't think they're done a lot, but if you have one that is bleeding, or you have repeat bleeding from gastric varices, of course you have to discuss them in a multidisciplinary context together with radiologists and surgeons. And in some cases, maybe surgery can be a solution. I remember cases where we have discussed it, but many of these actually developed their own shunts. So the varices were not that prominent. It was not a big issue in the long run, but discuss it with your surgeons and your radiologists for sure.
Somebody's asking about, this is really for you. What happens if the injector needle gets stuck or attached after you've injected the gastric varix with glue? Has that ever happened to you? I've heard of it happening. It's been reported. My answer is to pray
No.
if that happens, but
Yeah, pray. That's a good idea. But one of the good things about Lipidol is it's
Right.
if you use it a lot, we actually put the endoscope down in the Lipidol before we start. I didn't say that, but we do that because we need everything to be smooth,
Right.
and that's one of the good thing about Lipidol. So we use it. It's not actually a lot. It's not for the fluoro. It's because it's really gets everything working more smooth.
Exactly. There's that oil effect of the Lipidol. Yeah, exactly. Let me see what other questions there are here. Oh, somebody asked a question about, this is a good question. And this was asked actually for non-variceal bleeding. What do we do with patients who have thrombocytopenia or a really elevated INR? Are there specific numbers that we're looking for before we do endoscopic therapy? I'll let you go first. In other words, if their platelet count is too low, what do we do? Or if their INR is too high, what do we do?
What we often do is we do like a TEC, or we do a thromboelastography. We know that from traumatologists, and I know it from surgery. That is a really good idea. And that helps us to do a balanced transfusion ahead of endoscopy. If you have a patient that you don't think that is not able to coagulate, then you cannot do therapy. So I would suggest to do a thromboelastography, and then you talk with your bleeding guys and ask them which transfusion is suitable for this patient in this situation in order to restore their ability to coagulate. And usually they can help you. And it's also in these cases where they have had some medication that also interferes with the ability to coagulate. So
yeah, if they've been on an antithrombotic, what we'll do is generally we don't see a problem unless their platelets are really under 50,000. If they're under 50,000, we can give them a platelet transfusion. In terms of INR, and if you look at from the non-variceal, even if they have an INR of 2, if it's anywhere less than 2, we're gonna plan to do endoscopic therapy. There's no really good data to show that it's detrimental unless it's really a super therapeutic INR. So that's what we do, and that's what's really recommended. Somebody asked a question here really to me, do you usually band only the varix with the white nipple? My answer is no. I'll start with that, but usually, varices come, there's usually 3, 4, even sometimes 5 columns of esophageal varices, but I'll start at that nipple sign, and then I will continue to place bands on the other variceal columns as well. So not just to limit to that one varix. Do you agree or do something different, John?
No, I agree perfectly.
Somebody's asking about gastric varices. Any place for hemospray in gastric varices? Now, I talked about there's some data in esophageal varices. I don't know if there's anything more recent. I haven't looked recently in terms of gastric varices. I thought there was, though.
Well, in general, the evidence is much less robust for gastric varices.
Absolutely.
So that's just in general.
Right.
And I have not seen any papers, like real studies, supporting the use of hemospray for gastric varices. But of course, there may be something out there. But I don't think there is any high quality studies, at least, supporting it. I'm quite sure about that.
There's limited data in general in regards to topical agents in variceal bleeding, but it's almost all been exclusively with, as far as I can remember, and no on esophageals.
I agree.
Let's see. Somebody just said that they don't inflate the esophageal balloon in the UK, just the gastric part. Somebody else said that in Mexico, the Sunsteak and Blakemore is still available. So I guess it's still available, at least in maybe some parts of the world. How to treat post-banding ulcer bleeding. That's a good question. We'll see that with esophageal. Generally, the bleeding is not that bad. However, no, it's a difficult problem. You potentially can try and use a clip. I would not use thermocoagulation therapy on something like that. And this is really why we really want to try and prevent these. And that's why after we ban patients with esophageal varices, we do put them on a PPI to try and to prevent that from happening. Are you doing any sclerotherapy, John, at all for esophageal varices?
No, we're not.
We haven't done that in a long time either, but if that's all you have, if you don't have a band ligating device, sclerotherapy does still work. The problem with sclerotherapy is that there can be ulcerations afterwards. And you can sometimes get esophageal stricturing depending on how much is done over time. Somebody asked another question. I'm gonna take one or two more questions and then we're gonna have to close this since we're coming up on the hour. Do you have a nurse at night when you do endoscopy for these kinds of cases? Yes, we do for sure. And it's actually, it's an endoscopy nurse who works in our endoscopy department, who knows how to work with us and treat all types of bleeding. What about you guys, John?
I perfectly agree. I would say like pressing a needle into a varix. I guess that's not the hard part. It's a nurse who does all the tricky stuff and all the mixturing and preparing the needles and all that. And you have to have an experienced nurse. And usually we have some few that are really dedicated and know how to prepare these needles, so everything will run smoothly, because you have to it has to run smoothly when you stand with a varix like the one I included in my videos.
Yeah, I think it's really, first of all, you absolutely need to have a nurse assistant there. There are some places that will use nurses from other places in the hospital that have no idea about endoscopy or hemostasis. And I think today in 2021 that if you don't have that, you should be pushing your hospital administration to make sure that the endoscopy nurses from your unit are actually on call for these emergency cases. Any more to add, John?
Yeah, we have when we do peptic ulcer bleedings at night, then it's usually in the operating theater we do them. But if we encountered a case where we were, for instance, do glue a varix, then it would have to be our own nurses. Like if we did an ESCP at night, it would also need our own nurses to be called in, because there's too many technical matters that has to be taken care of, and you need the experience to do that.
Last question. What's the best treatment for GOV1 varices?
GV1?
GOV1.
I think it's, yeah. That's for sure. It's glue or a combination of glue and coils. Okay. Maybe if you have really, really small varices that can really be captured, so you can have a red out like the one you show, and you can put a band ligation on. Okay. But if they're too big, it's not a good treatment, I think.
Okay. Well, John, I want to thank you very much for your excellent presentation and being willing to take all these questions. We had some amazing questions. We had over 100 questions asked. We had almost 1,400 individuals registered, and we ended up topping out over 600 who were attending at some point here. I want to remind everybody, I want to thank everybody for attending. The recording of this webinar is going to be posted on the e-learning section of the ESGE website, and all of our past webinars are there. So you're more than welcome to go back and look at this one as well as previous webinars. I want to thank the governing board of the ESGE as well as our webinar team, Dave Inker and Gabriela Varga. Thank you very much for your support. Without you guys, we could not have been doing this tonight. I want to remind everybody that if you're not an ESG member, you should join because there's certain benefits, including online teaching, like my ESGE Tutor and the Kick app. I also want to remind everybody about ESGE Days 2021, which will be taking place online at the end of March. And you can go to the ESG website or type in ESGE Days 2021, and you'll get all the information there. And next Wednesday, ESG Wednesday webinars continues. It's going to be a satellite symposium sponsored by Norgine. It's an interactive colonoscopy debate, past, present, future. We have a great panel, amazing panel. Professor Ali Rapici from Italy, Professor Thomas Roche from Hamburg, Germany, and Professor Evelyn Decker from Amsterdam in the Netherlands. So that should make for a great webinar next week. And again, I want to thank everybody. John, I want to thank you. It was fun doing double duty here tonight. And I look forward to seeing everybody, at least virtually online at ESGE Days at the end of March. Thank you all and have a great evening. Bye-bye.